Hi, thank you for participating today in Advent Health's series, Under Pressure, session number 3. My name is Melissa Wilson, nurse practitioner with the pulmonary hypertension team at Advent Health Orlando. Today I'm joined by my panelists, Dr. Stacy Mandris, who is the Pulmonary Hypertension Program Director, and Dr. Alex Levine, who is the lead palliative care physician at Advent Health Altamont. Thank you both for coming today.
Hi, Melissa. Thank you for having us.
Thank you. So today we're going to talk about palliative care and pulmonary hypertension and how these two things, services come together to help our patients. So Dr. Mandris, tell us some about how you have utilized palliative care in your career dealing with patients who have pulmonary hypertension.
So, Melissa, in spite of all of the medical treatment options that have been developed since the first drug was approved to treat pulmonary arterial hypertension in 1995, this is still a progressive disease that is almost uniformly fatal. And even though our treatment options have been demonstrated to delay disease progression, our patients do get sicker over time. They are asked to take medications that are often quite arduous in terms of the requirements to wear a continuous infusion pump. They're associated with significant side effects. It's a big lifestyle change, as is living with this progressive disease that has quite significant morbidity as well as mortality associated with it. And so a growing piece of our practice has been our collaboration with palliative care. And a lot of people, physicians, patients, the community, don't really understand what palliative care is and how incredibly helpful it is to us and to our patients. And so we often rely on our palliative care colleagues to help us with progressive symptom management and helping patients cope with having a progressive, often fatal disease, what that means for themselves, what that means for their families, and end-of-life planning. And so those are the things that I'd like to expand a little bit more about as the three of us discuss this topic today.
So Dr. Levine, thank you again for participating, and we really do appreciate the services that your team provides to us and our patients. So tell us how we can facilitate utilization of palliative care in the care of these complex patients.
Yes, I think, like Stacy had mentioned, with pulmonary hypertension being a progressive disease and having high stressor burden when it comes to physical needs, emotional needs, spiritual needs, trying to identify these patients early on so that we can work alongside you and to help them understand their disease process and their expectations moving forward, and really find out what their goals are. As you already know, usually when you have the diagnosis of pulmonary hypertension, you probably have multiple comorbidities that are affecting the patient and also their families. So I think how to utilize this is to maybe using some screening tools to identify these high-need patients and get us on board early on, because the earlier palliative care is involved, the larger the impact they're going to have for them and their families.
So you described some tools, or mentioned that there's some tools that may be useful to us. So the evidence has been clearly documented that in most pulmonary hypertension programs, palliative care is either non-existent or gravely underutilized. So what are some tools that we can use for places that have services, or we have limited access to services, or what things can we do even early on with our patients before they end up in a hospital to help facilitate or initiate that conversation about palliative care?
Sure. There are several tools available. Like one of the things I like to use is kind of like an ESAS score, really finding out kind of what their symptom burden is, and it kind of goes over various things like their pain, their degree of shortness of breath, their any like nausea or vomiting, any anxiety, depression, any spiritual distress or financial distress, because I think a lot of times we are focusing a lot on the clinical side, but there's other things going on in patients' lives that's bringing them distress. So doing that kind of scoring system could probably bring to light of what unmet needs there are, and then also tracking how many times are they being hospitalized, how many, and what is their functional status over time? Is that progressively getting worse? I think those are clear indicators of prognostication when someone's functional status is decreasing.
Thank you. And Dr. Mandris, so I think often when we present the concept of palliative care to patients, and you mentioned that, of course, it's really about that symptom management, that supportive care, which Dr. Levine just eloquently described. How do we help facilitate this conversation in a way that patients understand the difference between palliative care and hospice? I would like both of you to explain how you would describe that to our colleagues.
So a lot of times when I'm talking with patients, as soon as they hear the word hospice, they think that we're giving up on them. And I make it clear to them that just because I'm involving palliative care, it doesn't mean that I'm going to stop treating them. I tell them that while we are very focused on their medical management, sometimes we can't see them as a whole, the whole picture in terms of how they are coping mentally, psychologically, making sure that all of their symptoms, whether it's shortness of breath or nausea, anxiety, whether all of these things are being addressed. And so I like to bring in palliative care to assist with how they're feeling, mind, body, and spirit, but also to help them plan for the future in case our medications don't work, and to help facilitate conversations about these difficult issues. What would I want if I were to stop breathing? It's hard for patients to talk to their families about these things, and that's another thing that palliative care is often very helpful in doing, is help to facilitate patients having end-of-life discussions with their family.
Mm-hmm.
Yes, I'll add on to that. Yeah, palliative care is basically an extra layer of support while you're receiving disease-modifying therapy. So, like Stacy had mentioned, it doesn't mean that we're stopping with their treatment plans. We're working alongside those treatment plans and really optimizing their quality of life as the disease burden increases. And if it gets to a point where either they're not tolerating treatment or the treatment's causing more distress than good, then to have those conversations and see if the transition to hospice is a good fit for them, and we would help with that transition as well.
And I think you bring up some great points in understanding that there's definitely two distinct services. Palliative care and hospice are not one and the same. So your goal really is to help tell us how you want to live your life with your chronic illness, versus hospice saying, help you as your life ends with this chronic illness. And I think it's such an important thing to emphasize to our patients as we communicate with them. Thank you for your time today and listening to our session about palliative care and pulmonary hypertension. Thank you for your participation and attendance in episode 3 of Under Pressure.